Hello, everybody, and welcome to our webinar, an overview of low vision rehabilitation with Dr. Delaram Shirazian. My name is Elena Sturman. I am the President and CEO of the Glaucoma Foundation. I would like to thank Dr. Shirazian and all of you for being with us today. The Glaucoma Foundation is dedicated to finding a cure for glaucoma. While each year we encourage and fund innovative research into glaucoma, our mission is also engage with and support glaucoma patients and people who care for them. Most of you are already familiar with our website and publications. We offer seminars like this one to provide you with interesting, informative content in a more interactive format. We really hope that you learned something new today and that is valuable to you. Thank you all for sending your questions to us in advance of this seminar. Dr. Shirazian will address them in her presentation and during our question and answer session. And now I am very excited to introduce you to Dr. Delaram Shirazian. She's a fellow of an American Academy of Optometry and is currently an assistant clinical professor at SUNY College of Optometry. She teaches the patient-doctor communication portion of the first-year curriculum at the college, is the instructor of the record of the low vision ocular disease micro-credential program, and she works with patients and students in primary care and low vision rehabilitation clinic. Ladies and gentlemen, please join me in welcoming Dr. Delaram Shirazian.
Thank you, Elena. Give me just a moment. I'm going to share my screen and then we will get started. All right, you can see my screen, Elena?
Yes.
Yes. All right, so we'll go ahead and get started this evening. Again, thank you everyone for joining us, and thank you to the Glaucoma Foundation for having me here this evening. So we are going to give an overview of low vision rehabilitation. So I know some of the members of our audience are patients, some are family members or caregivers, and some may be providers. So my hope is that no matter who you are, that this presentation, you take away something new and meaningful from it. So first I'll go through some objectives for this evening and what I will be discussing in particular. So first we're going to define what low vision is. I know someone had asked this question in our Q&A, and we'll also talk about what legal blindness is and how it differs from low vision. We'll then go into when to pursue low vision rehabilitation. Everyone is always wondering, okay, well, when do I need to do this? Docs also want to know, when should I refer my patients for this? So we will talk about that. And then I'm going to spend a majority of the time going over the basic components of a low vision evaluation. So kind of going from A through Z. And in that, I will talk about an introduction to low vision devices and technologies. So it will be a very brief introduction to these things because I could spend a whole webinar just talking about low vision devices, but I will be giving an overview of just some common ones that we may prescribe depending on someone's goals. I do also want to mention with that I don't have any financial disclosures with any of the products or the information that I will be sharing with you this evening. So let's jump right into it. So what is low vision? So low vision defined, if you look it up, it's going to have a lot of different definitions. It's not really one agreed upon definition, but the most common one that is cited is by the National Eye Institute. And it is defined as visual acuity that is 27 or poorer in the better seeing eye and cannot be corrected or improved with eyeglasses or contact lenses. So that last part is really important because people may think, oh, well, I don't see very well without my glasses or without my contact lenses, but when I wear them, I have good acuity. Well, that means you don't have low vision because the definition includes your best corrected vision with your eyeglasses or contact lenses. So what does 20/70 mean? So 20/70 means that someone with 20/20 acuity could stand 70 feet away from an object and be able to see it, whereas someone with 20/70 acuity would have to be standing at 20 feet, so much closer in order to see that object. Low vision is quite common in the United States. There is a prevalence of 1 in 25 adults, and the most common causes include glaucoma, diabetic retinopathy, and age-related macular degeneration. So next, we'll briefly discuss legal blindness and how that differs from the definition of low vision. So first off, legal blindness is actually a definition that's used by government agencies to determine if someone is eligible for resources. These resources include things like vocational training, schooling, disability benefits, etc. Here in New York State, we work closely with the New York State Commission for the Blind. That's our state organization when someone meets that criteria. So the criteria for legal blindness is the inability to read any letters on the 2100 visual acuity line. Again, this is in your better seeing eye with your best correction. So even if you have one eye that's 20/20 and one eye that's worse than 2100, you would not meet this definition since your better seeing eye is 20/20. So this definition has actually been updated. In 2007, it used to be if you had 2200 or poorer acuity, you would be considered legally blind. But since our visual acuity charts, which we measure your vision, have become much more precise, they now measure between 2100 and 2200. So if you're not able to read any letters on the 2100 line, you would meet this criteria. So one thing that comes up whenever I am evaluating someone and telling them that they meet this criteria for legal blindness is I always like to emphasize that this doesn't mean that you are blind and you can't see anything. This just means that you meet this criteria where your state organization will provide you with certain services and benefits because they recognize that you have a visual impairment. Legal blindness can also be based on your visual field. So there are certain conditions, glaucoma being one of them, other retinal conditions like retinitis pigmentosa that may severely impact your side vision or your peripheral vision before it impacts your central vision, or may not impact your central vision. So there is also a definition of legal blindness based on your visual field. So this definition is less than or equal to 20 degrees of visual field in the widest meridian in the better seeing eye. So you would, of course, without the proper test, you would have no idea how much degrees of visual field you have. So the legal blindness criteria is something that we can evaluate you for in the low vision examination. Your regular eye care provider, if they do the right testing, may also be able to tell you if you may be eligible for this as well. So next, when should I pursue low vision rehabilitation? This is a question we commonly get. When should I see a low vision provider? As docs, they want to know, when should I refer my patients to low vision rehab? And the answer to this is there's really no visual acuity or visual field cutoff that says this person definitely needs to see a low vision provider. It's when the vision loss interferes with daily activities. That's when we start to consider that low vision may be a good option for you. So this means it's very individualized and it's going to vary based on the person. So there's times where I've seen patients that have normal visual acuity, 20/20 in my low vision clinic, because they may have a condition that causes extreme sensitivity to light or glare, and they need a tint evaluation to look at different options for tint or glare control. And that's a great referral. I'd love to see those patients. And then we also get patients that do have reduced acuity or reduced visual fields to varying degrees. I would say if you do meet that low vision threshold or the legal blindness criteria, I certainly would recommend that. But anything beyond that is really going to vary based on what you do every day. So someone who has very mild visual acuity loss, who likes to garden and likes to listen to podcasts, they may not have very precise visual demands, and they may be okay with that slight vision loss. It's not really interfering with their daily activities. I wouldn't say that that person absolutely needs to see a low vision doc. Versus someone who likes to do fine needlepoint, they like to read the newspaper, the really small print, they may be really bothered by that really slight acuity loss, and that would be a great referral to a low vision provider. I will say if you do have a progressive condition, something that you know may get worse over time, I would recommend seeing a low vision provider sooner rather than later, because getting acquainted with a low vision doc, getting acquainted with magnifiers and different options that you have early on is just going to make it easier for the future and help you adapt even more. So how does a low vision exam differ from just your regular eye exam? Let's first talk about your regular eye exam or even your exam with a specialist like a glaucoma provider. So our typical comprehensive exam is really used to assess your vision, your binocularity, or how your eyes are working together, your refractive error or your glasses prescription, and the health of your eyes. So the focus is really on the eyes. If you're seeing a glaucoma provider or specialist, for example, they're really focused on your intraocular pressure or your IOP, your visual fields, maybe your OCT images. They really want to make sure that your disease is well controlled. The low vision exam, on the other hand, is really wanting to know and to figure out how you're functioning with the vision that you have and the current level of vision that you have. So we want to focus on how you're using your eyes and not just what your vision is or your eye pressure. And the whole purpose of the low vision evaluation is really to maximize the vision that you have remaining. So we have to work in conjunction with your eye care provider, because we need someone to still focus on the disease and to focus on your eyes. And then we can take care of how you're working with your eyes and making sure that we maximize the vision that's left. So there are a lot of components of a low vision exam, as I've laid out here. And so I'm going to briefly go over each of these. I do want to say that this is how we conduct low vision at my clinic and most of the places that I have worked low vision in, but wherever you may decide to go for a low vision evaluation, this may differ just slightly, but these are the basic components that will be covered in that exam. So before we jump right into that, I want to talk about how to best prepare for your low vision exam. So before you go in, we want you to send your provider or bring in your last eye examination with your current eye care provider. So whoever's managing your ocular conditions, because we want to make sure that you have had proper eye care in the past, because if you come to us, and this has happened before with a treatable condition, we may not pursue low vision. So an example of that would be like if you have really advanced cataracts, that you may benefit from cataract surgery, and that's causing some reduced vision. So we'd like that to be taken care of so that we can figure out what your best visual acuity is after all of that. So your last eye examination is really, really helpful to us. We also want you to bring in your current glasses and any low vision aids that you may have. Even if you think your glasses don't work for you, even if it's like a little magnifier you bought at the grocery store or on Amazon, it doesn't matter. We want you to bring that in because we want to see what you're currently using and what's working for you or what's not working for you. And then also before you come in, we want you to consider what your visual goals are. So a lot of times when people present to the low vision exam, a big goal is, well, I just want to see better. And yes, that is a good goal, but we have to narrow that down into specifics. So what do you want to see better? So things like reading a magazine, reading your mail and your bills, seeing the television and the closed captionings on the television. So that level of specificity is what we want for your visual goals, because low vision is very much a goal-based exam. So if you don't like to watch TV or you don't care that you can't read the subtitles, then we're not going to spend a lot of time figuring out ways for you to view the television. We're going to spend most of the time on the goals that you have for your vision. And again, this is going to be very individualized and very based on your visual demands and what you need. We also have a social work intake before our low vision exams in our clinic. And this is where one member of our social work team will contact you to ask you some questions in preparation for the low vision exam. So they'll ask you if you have any questions for the provider, your history of vision loss, if you've ever been connected to services before. And they also do a quick depression screening, which is really nice because a lot of times patients with vision loss may be at an increased risk of things like anxiety or depression. So they do that screening as well. And our social work team is really great at referring patients to certain services like mental health as needed. So let's get into the low vision exam. The first part is the case history. So this is pretty much similar to when you see your regular eye care provider. We want to know everything. We want to know the cause of reduced vision, if you've had any previous treatments before. If you're on a bunch of glaucoma meds, we want to know those. If you've had surgeries in the past, we want to know. We want to know your visual goals as well. We talked about this a little bit, but I'm going to emphasize this again, to come in with specific goals that you would want to achieve. But if you're not sure what your goals are, we can talk a little bit about how we can tease that out a little bit. We also want to know your other ocular history. If you've had things that have happened in the past that aren't specific to your cause of vision loss, that's still important to us. Your medical history. So a lot of times people may wonder, well, why does this low vision doc need to know my medical history and my medications? Well, the truth is we have to take everything into consideration when we're figuring out the best treatment and management plan for you. So for example, if someone has arthritis, they may have difficulty grasping a handheld magnifier, and we may not think that device would be proper for them. So that this history that we get really also helps us determine the devices that may be best for you. We also ask about your medications, allergies, etc. So basically your full ocular and medical case history. We then move into the ADL questionnaire, and ADL stands for Activities of Daily Living. So this is a great time where if you're not sure what your visual goals are, where we can kind of help you determine what you want to focus on in the exam. So this is a little snippet from our electronic health record system of our ADL questionnaire. So we ask things to figure out how you're functioning with your current level of vision. So are you able to do your housework? Can you cook the food that you need to cook without burning or cutting yourself? Are you able to take your medications and read the labels on your medications? Are you experiencing difficulty with things like reading your mail or handwritten material? We ask about how you're getting around. So here in New York City, do you take public transit? Are you driving? Do you feel safe doing so? And can you do that by yourself? We also want to know your hobbies. So it's not just about what you do every day, but what you like to do as well. And lastly, your occupation. If you're currently working or in school, that's also important for us to know because we want to make sure that you're able to do that with the level of vision that you have. So after we do our extensive case history, our ADL questionnaire, it's now time for us to measure your visual acuity. So sometimes the charts that we use in the low vision exam may differ from the chart that's used in the regular eye exam. And one of the reasons for that is it has very good contrast, meaning that the black letters are very black and the white background is very white. And the chart is also mobile. So this is an example of what's called an ETDRS chart, and it's actually on wheels. So we usually start it at a set test distance, but if you're not able to see the letters, we can also move it closer. And we can also use other mobile charts in order to best figure out what your visual acuity is coming in. We like to test each eye individually and both eyes together, both far away and up close. After we check your visual acuity, the next major thing that we do is what's called a trial frame refraction. So a refraction is just a fancy word for measuring your glasses prescription. So this is an example of a trial frame refraction here. So the patient is wearing kind of a big funny pair of glasses that allows us to insert and remove lenses from it. This is a little bit different than how they do it in the typical eye exam, where they will use what's called a phoropter or a very large machine that's much easier to change the lenses in. But there's a couple of reasons why we prefer the trial frame refraction in the low vision evaluation. The first is that it allows us to make much larger changes in the prescription. So if you're not able to discern a difference between two very similar lenses, we can also change that power to make sure that we're finding the best prescription for you. It also allows you to move your head and your eyes into your preferred way of viewing. So with the other big machine, it can be really difficult to what we call eccentrically view or view from an outside area in your eye and not your center vision. But with the trial frame, it can be much easier to utilize your head movements if necessary. So we do the trial frame refraction first at distance, and then we also will find you a near prescription as well. So this is always the first thing that we do. So we talked about, the definition of legal blindness. We want to make sure that we first have your best prescription and your best visual acuity. So that helps us determine whether or not you meet that criteria. But that also is going to be the foundation for, trialing devices. If you're not wearing the correct distance or near prescription, it's going to also alter how you see out of those devices. So this is kind of like our first step in making sure that we're on the right path. So one thing a lot of times I will say is sometimes people are disappointed because they come in and think that they just need a new prescription and everything's going to be okay after they get glasses. And it's good to know that oftentimes in order to meet visual goals, we may have to go beyond just glasses. And we'll talk about those devices in just a bit. So after the trial frame refraction, we may do some additional testing. So things like contrast sensitivity to see how well you see a dark letter or an object on a white background, a visual field. So we talked about how that may qualify someone as legally blind, but that also helps us determine, where they may have areas of vision that they can't see. And also an Amsler grid. So that's the grid that I have here. It's like a checkerboard pattern. So we can actually utilize this if someone has something called a central scotoma or something in the center of their vision, an area of vision loss in the center of their vision. We can actually map it out using this so that we can figure out where to kind of have you look, to look around that area. And this also helps us determine the devices that we may trial based on the results of our additional testing. So we don't do these on every single patient every single time, but just depending on the condition and the concerns that someone has. So after that, now we're ready to trial devices. So at this point, we've obtained a lot of information. We've gotten your entire ocular history, your medical conditions. We've talked about your vision goals. We've checked your glasses prescriptions. And now we're ready to figure out what devices are going to help you meet your needs. So again, I'm just going to be briefly reviewing some very common devices that are used for near and far away, and some cool electronic devices that are up and coming. So the most simple near device is a high-powered reading prescription. So this is really nice because it is hands-free, and glasses are something that is familiar to most of us. So it's kind of easy as far as training and using. Usually the working distance or the distance from which you need to hold your reading material is much closer when we do high-powered reading glasses. And it may or may not meet your needs depending on your level of vision and the cause of vision reduction. The next device here is a a stand magnifier. So this is a magnifier that enlarges the image with an optical lens, and it also can be illuminated. So there is a switch on the handle where you can turn a light on. So this actually sits on a page, and you can just move it along the page, so you don't have to hold it up the entire time. So this can be utilized for prolonged reading. So this picture here is somebody reading a magazine. The next and also very common device is just a handheld magnifier. This is one like the traditional ones where you hold it above the page, and they also come illuminated as well. And again, the power of this varies just depending on the level of vision, the patient's goals, but this is going to be for short-term reading. So it's very difficult to sit there and hold a device up for an extended period of time to read a book, for example, but this could be really good for spot reading, what we call. So reading your mail for, a couple of minutes before your arm gets too tired. Some other common near devices include, this device here is called an optivisor. You can put it on your head, and the magnifying lenses actually flip up and down. And it's also really good for hands-free tasks. So one thing that always comes to mind is fishing. So if someone likes to go fishing and they can't see the hook and the string in order to string their line, this is a really hands-free device that's easy to kind of move up and down in order to see fine details up close. The center image here is a Ruby handheld CCTV, and CCTV stands for closed circuit television. So this is magnification that's done electronically. The nice thing about this is that you can actually adjust the level of magnification. All of the other devices, the magnifiers, the glasses, this visor, it's a fixed amount of magnification. So you can only order that device in one power, versus the Ruby actually has adjustable magnification. It also has adjustable contrast. So you can actually make the black blacker and the white whiter, so enhancing the contrast. You can also reverse the contrast. You can look at a newspaper print with white writing and a black background, which some people find a little bit easier to see, just depending on the condition. And this is also quite portable, so you can bring it around with you if needed. And this last device on this slide here is a desktop CCTV. So it's the larger version of this Ruby portable device. So this uses a monitor and a tray here. So you put your reading material on the tray. You can also adjust your level of magnification. You can also adjust the contrast. There are some newer CCTVs that have come out with text to speech functions. So instead of just reading the print on the monitor, it'll actually read it out loud to you. So if you have trouble seeing it on the screen, it can utilize audio to read print aloud, which is really, really nice. So of course, this one's not going to be portable. You're going to have a space in your home or your apartment to set this up, because it's pretty heavy, pretty large. It's probably going to need to stay in one place. So some common distance devices. The first one here is a handheld monocular telescope. So this is utilized a lot for spot reading in the distance. So if you're waiting for the subway and you want to know how long, how many more minutes your train has, this is a really nifty device to just kind of put over one eye, focus it, see what you need to see, and then put it back down. It's obviously not going to be great for prolonged distance tasks, but what we call those spot tasks. Another example, if you're crossing the street, you want to see what intersection you're at and you're looking a block away, you could utilize this telescope in order to read that sign. The next device here is something called the Max TV. So this one is actually for prolonged distance viewing, and it is a glasses system that has kind of focusable eyepieces, and you focus those to see in the distance. The reason why it's called Max TV is because seeing the TV is one of the more common distance goals that we have. But you could also utilize this if you're someone who, pre-COVID and hopefully post-COVID, likes to go see Broadway shows or sporting events, any place that you are going to not be walking around, because whenever we're magnifying things in the distance, we're also reducing our visual field because everything is magnified. So these devices must be utilized, the Max TV, when you are stationary, so sitting down. They're not safe to walk around with. And then the last distance device here is a pair of glasses with a telescope attached to them. Oftentimes, these are called bioptic telescopes, and they can be utilized for driving in certain states. So you don't look through the telescope the entire time, but it's almost like having like a side mirror on your car. So you're looking out of your regular distance glasses, and then you can tilt your head down and look through the telescope when you need to see something small and far away. So these can be utilized for driving in certain situations or just day-to-day life. So a couple of new technologies. I know everyone's always usually interested in what's new and upcoming in low vision devices. Well, the first thing I want to discuss is this image on the right. This is actually the built-in magnifier on the iOS iPhone device. So you don't have to have an app for this. It's in the accessibility options under the iPhone settings. And if you turn on the magnifier, the camera is utilized in order to basically have an electronic magnifier right there on your phone. So with this little sliding scale, you can increase and decrease the level of magnification. And with these three little circles down here, if you can see my mouse, you can also change the contrast, which is really, really cool. The other application that I often recommend is an app that's free on iOS called Seeing AI, and that stands for Artificial Intelligence. So this utilizes artificial intelligence in order to do a lot of things. The first thing it does is it can actually read text out loud to you. So if you simply take a picture of a piece of paper, it will read it out loud to you. So if you're unable to see the print, it utilizes audio. You can also scan products with it. So if you have 2 cans of soup at the grocery store or in your pantry and you're not sure if one's chicken noodle or one's tomato, you can actually scan the barcode. And for common common household items or pantry items, it will actually tell you out loud what you're holding, which is really, really awesome. It also can identify people. You can store faces in it, and also colors as well. So it doesn't claim to be 100% accurate because it is artificial intelligence, but it is a really cool free app that I recommend checking out. A few other wearable devices with new technologies. This is called the OrCam device, this first device here. It's about 4 inches by 1 inch, and it clips onto the side of your glasses. And on the front end, there's actually a camera, and on the back end by your ear, there is an audio output. So the OrCam device utilizes the camera and brings it to audio so that you're actually listening to what you're looking at. So for example, if you want to read a newspaper, you can put your finger where you want the OrCam to start reading, and it'll actually start reading the text out loud to you. It does utilize similar functions as Seeing AI. You can program people's faces into it. It can recognize colors, barcodes, very similar things. Next is this Iris Vision device. This is a head-mounted wearable augmented reality device. So it utilizes the Samsung phone device to magnify things and also overlays. So one thing it has here is this bubble on this picture where it will magnify whatever is in that bubble. And it also has like reading view. It has audio output as well. But you cannot walk around with this device. Again, your side vision is going to be severely impacted because you're wearing a head-mounted wearable device. So this is also utilized when you are stationary. There's a few non-optical aids that we utilize. The typoscope is seen here, where it's just a black piece of plastic essentially with a cutout in it to help isolate the lines when you're reading. Bump dots are tactile little stickers that you can put on things like your appliances at home, so you know where the 1-minute button is and the start button is on your microphone. And even things like large print playing cards. I feel like there's so many easy little low vision aids that we often forget about. So after we look at devices, your provider for low vision may or may not look at ocular health, depending on if we have your records from your other provider. So we may check your eyes with a slit lamp, which is just the microscope that we use to examine your eyes. We may check your eye pressure. We may dilate your eyes as needed, but usually if that's done with an outside provider, we don't repeat that testing. So after the low vision exam, you can return for the device dispense and training as necessary. So we never just want to give you a device and have you go home with it. We want to make sure that you're able to use the device properly. And then we make the appropriate referrals, both to our social work team, the Commission for the Blind, or other state agencies, at least in New York State. So just as a quick review, the major points: there's no visual acuity or visual field cutoff for low vision rehab. So whenever you feel like your vision loss is impacting your daily life is when we want to see you. The low vision exam focuses on how you're functioning with the level of vision that you have and strives to maximize the vision that you have. There are a wide array of low vision devices to meet needs, and this was just kind of a sample of what's out there. And we really have to work together in an interdisciplinary approach to make sure that someone's taken care of, both with their eye care provider, our social work team, the New York State Commission, everyone works together. So that was a very brief overview. So I want to thank you for your attention, and I would be happy to answer questions at this time.
Thank you so much, Dr. Shirazian. This was very interesting, and I'm sure our audience learned quite a bit. And perhaps our next webinar will be just on the devices, because I know you just touched upon it briefly, but there is a whole world of interesting devices, and maybe we'll talk about it. So I would like to start with questions that we received in our email prior to this event. Our audience, you can also ask a question in the question and answer button that you have on your screen. I apologize if you don't get to your question. You can always email it to us and we'll do our best to respond to you. So with that, the first question is, how do you find a low vision specialist?
Yeah, so this is a really great question, because people are often wondering, okay, well, I think I'm ready for low vision, or I think I need it. How do I find a provider? And I would say the first place that you should go to is your regular eye care provider. So whether that's your general ophthalmologist or optometrist, whether that's your glaucoma specialist, and let them know that you're interested in low vision services, because they will likely have someone or some place that they will refer you to. So I think it's best to first go through your eye care provider. And then it really varies based on your state and where you're at. So I know in New York State, we do have to be certified in low vision rehabilitation in order to practice here. And there is a website called Primary Care Opt, which is opt.com. And that has a list of providers that are actively doing low vision. I'm not sure if it's completely comprehensive, but unfortunately, as far as I know, there's no like national list. So I would recommend just reaching out to your regular eye care provider to start with.
Thank you. It was actually a follow-up question, but you covered it. What if there is no low vision specialist in your area? But you answered it already, looking on the website and talking to your provider. Next question is, are there any tools, technology to help to improve vision due to visual field loss?
Yeah, so visual field loss or peripheral visual loss is going to be rehabbed a little bit different than central vision loss. So if someone only has peripheral field loss, we may consider things like prisms. So prisms are something that we can either put in your glasses prescription or stick on your glasses. And prism actually redirects the image. So it takes the image from the area that's not seeing and moves it to the area that is seeing. So we can actually move the image a little bit. This obviously is not just going to be a quick fix where we give you a prism and you're all good to go. This also requires a lot of training to make sure you're utilizing it properly. And we also recommend something in our clinic called scanning training. So whenever you lose visual field or peripheral vision, oftentimes the eyes don't make proper movements into that area of vision loss. So the eyes aren't scanning their visual field as much as they should. So we actually do in-office vision training as well as home training in order to help the eyes scan their environment more properly or more accurately so that you're able to still get that full visual field image with the visual field loss.
Thank you very much. Next one is, can a low vision therapy rehab help with driving and specifically keeping your driver's license?
Yeah, so driving is a really big thing that we cover in low vision. So the driving requirements, I guess I'll say that the DMV creates the driving requirements and the laws. Our job is just to follow those and make sure that you are safe to drive. So the level of vision and the visual field that you need to drive is going to vary greatly based on the state that you're in. So I can talk a little bit about New York State, where there's a visual acuity cutoff that you need for a regular license. They also allow restricted driver's licenses, and they also allow driving with a bioptic telescope. So one thing we can do is we can check your vision, we can check your visual field to see if you meet that criteria. If you do, then we can also talk about whether or not you meet the criteria for a bioptic. But beyond that, there's nothing that we can do to make your vision better for the driving test or to increase your peripheral vision so you pass the driver's test. At least in New York State, there's no field expansion that we can do. So if you're wondering about whether or not you're safe to drive or whether you meet that requirement, I would recommend reaching out to a low vision provider in your state.
Thank you. Next one is there a checklist of therapies or procedures to try when glasses no longer fix declining acuity?
Yeah, that's a great question because people often want to know, okay, what's the first thing I should do? And where do I go from there if that doesn't work? And hopefully I've emphasized that low vision is very much an individualized approach. So there's no checklist or step of 1, 2, 3 that you should follow if glasses aren't working. I think the first thing that I would recommend is to talk to your regular eye care provider. Let them know that you're still not able to do your daily tasks or what you want to do with the level of vision that you have, and that you think that a referral to a low vision doc would be something that you're interested in. And then along with your low vision doctor, you can decide what would be best for you as far as treatments, devices, because it's going to be so varied and individualized based on your visual condition, your visual acuity, etc. So I would just first start with having that honest and open conversation with your usual doc.
Thank you. Next one is very interesting, and I think people with glaucoma will really appreciate this question. Do glaucoma patients have a higher risk of getting Alzheimer's?
Yeah, so this was asked, I think, at least 1 or 2 times in our emailed questions. So I also did a little bit more research on this just to make sure that I was up to date on my information. And there have been studies to see if glaucoma and Alzheimer's are related, because they both are considered neurodegenerative conditions. So there was one particular study that looked at patients with Alzheimer's and patients that didn't have it in the same age group. And they found that the patients with Alzheimer's had a little bit of an increased chance of having glaucoma versus the regular group. well, we don't have enough information to know if that study is really a representation of what's really going on, or if there's any cause and correlation, or if that's just due to chance. So I think right now there's a lot of research being done right now to figure out the exact mechanism of glaucoma, because there's a lot of theories, but nothing yet that is completely set in stone. So I'd say that it's just, there's not enough information to really say for sure. But I think we may see that in the future, but for right now, the jury remains out.
Thank you. Thank you very much. The next question, you touched upon it really briefly, but maybe you can answer it a little more in depth. Any ideas for how to help somebody dealing with emotional aspects of losing vision and something as meaningful as sight?
Yeah, I really like this question because we bring it up a lot in our low vision discussions too, and asking people how they're doing with their vision loss. Because as I had mentioned, there are studies that do show that people with vision loss may be at an increased risk of conditions like depression. So just like it's important to manage the physical aspects of vision loss, it's also important to manage the emotional and the mental. So one thing that we do in our clinic is we can refer patients to mental health services. So our social work team works with our patients to find somebody in their area that they could see to talk about those concerns and issues. Here in New York City, the Lighthouse Guild actually has mental health providers that work with patients with vision loss, which is really nice. So if you're wondering if there's a mental health provider out there in your area that works specifically with patients with vision loss, I would ask your local low vision provider to see if they would have a referral for you. And then the other thing is peer support. So I think reaching out to a support group is really, really important. And sometimes just hearing other people's stories and sharing your own can really kind of help make you feel less isolated and alone in vision loss. So I know that the Glaucoma Foundation does have glaucoma support groups. I think me and Elena were talking, maybe in the future they'll have just a regular low vision support group, which can also help with that. And again, this is going to just vary based on the location that you're at. But in our low vision clinic before COVID, we also had a support group for patients as well. So I think reaching out and utilizing those services could greatly help.
Thank you. There is a repeating question from our live audience, and it's for you to repeat the name of the website that you can find the low vision specialist.
Yeah, it's primarycareopt.com, and that's just for New York State. So I'll write it in the chat.
Perfect.
So then that way. Okay, so it's in the chat box.
Excellent. Thank you. Next question is, do you recommend mobility training with a cane, even if you don't need one yet, just in case you may need one in the future?
Mm-hmm. Yeah, so mobility training with a cane, for us, we will refer patients for that, of course, when they meet that level of legal blindness based on their visual field, or if they're having issues with their mobility. So they're not comfortable walking up and down stairs or navigating their environment safely, or if they've lost a significant amount of inferior visual field loss, which can really impact mobility. But I think it's really just going to vary based on the person, whether or not we will do that before visual loss is actually there, because usually we don't. But if we do know that someone is going to definitely lose peripheral vision in the future, we may connect them to an orientation and mobility specialist so that they can at least get the process started. But I don't know that they would actually do the cane training before vision loss is there. But that would be something that we would be able just to connect them with to see if they would benefit from that.
Thank you very much. And I know you covered it in your presentation, but perhaps one of the members of the audience missed it. Would you please repeat again, what is the determination to be legally blind?
Yeah, so legal blindness can be determined based on your visual acuity or your visual field. So it's when you can't see any letters on the 2100 line in the better seeing eye with your best correction. So with visual field, it is 20 degrees or less of visual field in the widest meridian in the better seeing eye. So I know that's kind of a mouthful, but if you're, if you need that repeated, if you just do a quick Google of like legal blindness USA, it is a national definition, and that should hopefully come up.
One question that just popped up was, does insurance cover the devices for low vision? And
Yeah.
perhaps what is covered and what is out of pocket?
Yeah, this is a really, really good question. So unfortunately, most insurances do not cover low vision devices. And I think this is obviously a very big topic up for debate. But the one insurance that covers, at least that I know of in New York State, is just straight Medicaid. So not a managed Medicaid like Fidelis, but just straight Medicaid will cover materials, including glasses for patients, and that includes low vision devices. But unfortunately, most other insurances do not cover these devices. So ways that we can help patients pay for these devices, at SUNY in particular, we have a board fund. So if someone cannot pay, they can fill out paperwork with our financial team, and we have a sliding scale based on the person's financial status. And we can work with them in order to figure out how to make the device affordable for them. So that's one thing that we can do at SUNY, but unfortunately, most insurances don't cover the devices.
Yes, unfortunately.
I will say one other thing, the Commission for the Blind, at least in New York State, if you are in school or if you're needing a device to keep your job, oftentimes they will pay for the devices, but I don't want to say every time. It just depends on the situation and why the device is needed.
There is another question in the chat. If a patient had a panoptic lens implanted and the lens folded and the patient is in the process of recovery and vision is presently low and will remain so for the next 3 months, would the patient with low therapy help this patient?
Yeah, I mean, I think even if there's vision loss for a temporary amount of time, I think it may be worth pursuing low vision rehab, especially if it's interfering with your daily life. So when patients come to us and they may have reduced acuity for a short period of time, whether or not they're going to get treatment or surgery to help that, we often try to figure out temporary or easy ways. So instead of, purchasing a really expensive device like a desktop CCTV, we may be able to train you on utilizing your iPhone functions, or, trying to make do with a magnifier that you can still use afterwards. So we can still provide you with some kind of tips and tricks to get by in the meantime until your vision hopefully improves.
Thank you. So basically, yes, they should absolutely seek low vision therapy.
Yes.
And does Medicare pay for the low vision evaluation?
Usually, yes. So usually we bill your medical insurance when you come for a low vision evaluation, since your vision loss is due to a medical condition. So Medicare would cover that. It's the refraction portion, or the determination of your glasses prescription, that medical insurance, including Medicare, usually does not cover. And that fee varies based on the provider and the institution that you're seeing. So I'd recommend calling ahead and asking about that charge before.
Thank you very much. Well, I believe we answered most of the questions. I would like to thank Dr. Shirazian very much for this wonderful webinar. I would like to thank our audience for participating, for being with us, for asking questions. It's not the last webinar on low vision therapy. We will bring Dr. Shirazian back to talk about all the devices. Meanwhile, it was recorded. It will be on our website, Glaucoma Foundation website, in about 10 days. So if you wanted to listen to it again, if you feel you missed something, it will be there for you. And I just wanted to wish everybody a safe and peaceful holiday season, and be healthy and be well. Thank you all so much for being with us today. Bye-bye.
Thanks, Elena.
Thank you very much.